Hello, I'm Maruk Said, your microbiology guide. Let's explore in-depth micro techniques and uncover groundbreaking insight together on this educational journey into the fascinating realms of microbes.
Gram Positive Cocci made easy. Staphylococcus and Streptococcus. Medical Microbiology Lecture. Table of Content. Gram Positive Cocci of medical importance. Staphylococci. Staphylococcus aureus. Staphylococcus epidermidis. Staphylococcus saprophyticus. Streptococci. Group A Streptococcus. Streptococcus pyogenes. Group B Streptococcus. Streptococcus agalactiae. Group C and D of Streptococci. Group D Streptococci. Enterococci and non-enterococci. A hemolytic Streptococci, Viridans group. Streptococcus pneumoniae, the pneumococcus. Gram Positive Cocci of medical importance. Medically important Gram Positive Cocci are primarily divided into two groups: Staphylococci, Streptococci. Staphylococci typically appear in grape-like clusters under the microscope, while Streptococci are arranged in chains or pairs. Staphylococci are catalase positive, producing bubbles with hydrogen peroxide, whereas Streptococci are catalase negative. Staphylococci are facultative anaerobes commonly found on the skin and mucous membranes, often associated with abscesses, wound infections, food poisoning, and toxic shock. Streptococci, on the other hand, are usually part of the oral, respiratory, and genital flora, and are associated with diseases such as pharyngitis, scarlet fever, rheumatic fever, pneumonia, and neonatal sepsis. Both groups include commensal species that are harmless under normal conditions, but can become opportunistic pathogens when host defenses are compromised. Differentiation between these two groups is essential for clinical microbiology and guides diagnosis and antibiotic therapy. Staphylococci. Staphylococci are broadly classified into coagulase positive and coagulase negative species. Classification of Staphylococci. Coagulase positive Staphylococci. Staphylococcus aureus is the primary coagulase positive species of medical importance. It produces the coagulase enzyme, which causes plasma to clot by activating prothrombin, thrombin. Thrombin then catalyzes the conversion of fibrinogen to fibrin clot. Among human pathogens, the most significant staphylococci are Staphylococcus aureus, coagulase positive, highly virulent; Staphylococcus epidermidis, coagulase negative, opportunistic pathogen; Staphylococcus saprophyticus, coagulase negative, associated with urinary tract infections. Staphylococcus aureus is differentiated from other staphylococcal species by mannitol fermentation on mannitol salt, agar, produces yellow colonies due to acid production. Hemolysis on blood agar typically shows beta hemolysis, clear zone around colonies due to complete RBC lysis. Coagulase negative Staphylococci. Staphylococcus epidermidis, common on skin and mucous membranes, associated with prosthetic device infections, endocarditis, bacteremia, and urinary tract infections. Staphylococcus hominis colonizes areas with apocrine sweat glands, occasionally implicated in bacteremia and device-related infections. Staphylococcus capitis, found on scalp, face, and external ear, may cause endocarditis and bloodstream infections, especially in neonates. Staphylococcus saprophyticus inhabits the skin, intestine, and vagina, second most common cause of community-acquired urinary tract infections in young women. General characteristics of the Staphylococci. Commonly inhabit the skin, anterior nares, and mucous membranes of humans and animals. Appear as spherical, cocci, cells, arranged in irregular grape-like clusters under the microscope. Gram-positive organisms that retain crystal violet dye. Non-spore forming and non-motile, lack spores and flagella. Some species may possess a capsule, aiding in resistance to phagocytosis. Facultative anaerobes, capable of growth in both aerobic and anaerobic conditions. Relatively resistant to drying, heat, and high salt concentrations. Can grow on media with up to 10% NaCl. Currently, about 31 recognized species, with only a few being significant human pathogens, e.g., Staphylococcus aureus, Staphylococcus epidermidis, Staphylococcus saprophyticus. If you have watched till here, don't forget to subscribe to Family of Science Lovers. Press the bell icon button so you are always updated. Staphylococcus aureus. Staphylococcus aureus morphology. Shape: spherical, cocci, about 0.5 to 1.5 micrometers in diameter. Arrangement: typically found in irregular grape-like clusters, occasionally seen in pairs or short chains. Gram reaction: gram positive, appearing purple under gram stain. Colony characteristics: on nutrient agar, round, smooth, convex colonies, 2 to 4 millimeters. Pigmentation: often produces a golden yellow pigment. Aureus equals golden. On blood agar, shows beta hemolysis, clear zone around colonies. Motility and spores, non-motile and non-spore forming. Capsule, may produce a polysaccharide capsule, enhancing resistance to phagocytosis. Cell wall, thick peptidoglycan layer with teichoic acids. Contains protein A that binds the Fc region of immunoglobulin G, interfering with opsonization. Growth conditions: facultative anaerobe, tolerates high salt concentrations, up to 10% sodium chloride, and grows well on mannitol salt agar. Fermenting mannitol, colonies turn yellow. General characteristics of Staphylococcus aureus. Staphylococcus aureus grows in large, round, opaque colonies, often producing a golden yellow pigment that gives the species its name, aureus, golden. The optimum growth temperature is 37 degrees Celsius, but it can also grow over a wider temperature range. It is a facultative anaerobe, capable of surviving and multiplying in both aerobic and anaerobic conditions. Demonstrates remarkable environmental resilience, being able to withstand high salt concentrations, 7.5 to 10%, which allows growth on mannitol salt agar. Wide pH variations, relatively high temperatures compared to many other non-spore-forming bacteria colonies often show beta hemolysis on blood agar, indicating complete lysis of red blood cells. Produces a wide array of virulence factors that contribute to pathogenicity, including enzymes such as coagulase, hyaluronidase, lipases, deinases, and staphyloconase, toxins such as hemolysins, enterotoxins, food poisoning, exfoliative toxins, scalded skin syndrome, and toxic shock syndrome toxin. Surface proteins like protein A, which binds the Fc region of immunoglobulin G and disrupts opsonization and phagocytosis. Its ability to persist under harsh conditions and produce multiple virulence factors makes Staphylococcus aureus one of the most important opportunistic and pathogenic bacteria in humans. Variation in Staphylococci. A culture of Staphylococcus often contains subpopulations of bacteria that differ from the majority in colony characteristics, size, pigment production, hemolysis, enzyme production, drug resistance profiles, pathogenic potential. The expression of these characteristics can be influenced by in vitro growth conditions such as medium composition, oxygen availability, and pH. Some isolates may show altered phenotypes, for example, smaller colonies, pinpoint colonies, loss or reduction of hemolysis. These variants are termed small colony variants. Small colony variants are associated with enhanced intracellular survival, persistence in host tissues, contribution to chronic, relapsing, and antibiotic-resistant infections. Virulence factors of Staphylococcus aureus. Enzymes. Coagulase coagulates plasma and blood, produced by approximately 97% of human isolates, serves as an important diagnostic marker. Hyaluronidase breaks down hyaluronic acid in connective tissue, facilitating bacterial spread. Staphylokinase dissolves blood clots, fibrinolysis, promoting dissemination. DNase hydrolyzes DNA, reducing viscosity of pus and aiding bacterial mobility. Lipases break down lipids and oils, enhancing survival and colonization on skin and sebaceous areas. Penicillinase, beta-lactamase, inactivates penicillin and contributes to antibiotic resistance. Toxins, hemolysins, alpha, beta, gamma, lyse red blood cells and also damage leukocytes, platelets, and tissues. Leukocytin destroys neutrophils and macrophages, weakening host immune defense. Enterotoxins, heat-stable exotoxins that cause gastrointestinal distress, nausea, vomiting, and diarrhea, common in food poisoning. Exfoliative toxin causes separation of the epidermis from the dermis, responsible for staphylococcal scalded skin syndrome. Toxic shock syndrome toxin, superantigen that triggers massive cytokine release, leading to fever, rash, vomiting, shock, and multi-organ failure. Epidemiology and pathogenesis of Staphylococcus aureus. Widely distributed in nature and commonly present in human environments. Can be readily isolated from fomites such as clothing, bedding, door handles, and medical equipment. Carriage rate among healthy adults is estimated at 20 to 60%. Common sites of colonization include the anterior nares, skin, nasopharynx, and occasionally the intestine. Predisposing factors for infection include poor personal hygiene and malnutrition, tissue injury or open wounds, pre-existing infections that weaken host defenses, chronic illnesses such as diabetes, mellitus, immunodeficiency states, HIV, chemotherapy, steroid use, etc. Infections often arise from the host's own carriage strains, endogenous source, but can also spread by direct contact or contaminated objects. A major clinical concern is the rising prevalence of community-acquired methicillin-resistant Staphylococcus aureus, which poses challenges due to multi-drug resistance. Staphylococcal disease. Infections caused by Staphylococcus aureus range from localized skin infections to serious systemic diseases. Localized cutaneous infections. Localized cutaneous infections occur when bacteria invade the skin through wounds, hair follicles, or sebaceous glands. Folliculitis, superficial infection of a hair follicle, often mild and self-limiting, though it can progress to deeper lesions. Furuncle, boil, painful, pus-filled abscess developing from an infected follicle or sebaceous gland. Carbuncle, a larger, deeper, and more serious lesion formed by the interconnection of multiple furuncles, often associated with systemic symptoms like fever. Impetigo, Staphylococcal impetigo, bubble-like vesicles or pustules that rupture, crust, and peel away, highly contagious and most common in newborns and young children. Systemic infections, septicemia, bloodstream infection that can originate from any localized lesion, such as skin abscesses or wound infections. Endocarditis, infection of the endocardium or heart valves, occurring in both normal and prosthetic valves, often associated with intravenous drug use or indwelling medical devices. Osteomyelitis, bone infection that may arise through hematogenous spread from a distant site or by direct invasion from trauma, surgery, or local wound infections. Bacteremia, presence of bacteria in the bloodstream, often seeded from another infected site or linked to medical devices, e.g., catheters, prosthetics, IV lines, can progress to sepsis or metastatic abscesses. Toxigenic disease. Food intoxication, staphylococcal food poisoning, caused by ingestion of preformed heat-stable enterotoxins in contaminated food. Rapid onset, 1 to 6 hours, of nausea, vomiting, abdominal cramps, and diarrhea. Self-limiting illness usually resolves within 24 hours. Antibiotic therapy is not required. Enterotoxins. About 15 enterotoxins, A to E, G to P. All are superantigens. Approximately 50% of S. aureus strains produce one or more enterotoxins, heat-stable and resistant to gut enzymes, produced when bacteria grow in carbohydrate and protein-rich foods. As little as 25 micrograms of enterotoxin B can induce symptoms. Mechanism: toxins stimulate gut neural receptors, activating the CNS vomiting center, emetic effect. Genes for enterotoxins, exfoliative toxins, and TSST1 are carried on a pathogenicity island, often mobilized by bacteriophages. Staphylococcal scalded skin syndrome, caused by exfoliative toxins, exfoliatins A and B, act as proteases that target desmoglin 1, disrupting epidermal cell junctions. Clinical features: painful bright red flush, followed by blistering and desquamation of the epidermis, most common in neonates and young children. Toxic shock syndrome, mediated by toxic shock syndrome toxin 1, a superantigen, causes nonspecific T-cell activation, cytokine storm, fever, rash, vomiting, diarrhea, hypotension, and multi-organ failure. Classically associated with tampon use, but also linked to nasal packing, surgical wounds, and device-related infections. Clinical features appear within 8 to 12 hours: high fever, hypotension, diarrhea, rash, erythroderma, multi-organ involvement, shock, renal, hepatic dysfunction. Treatment: remove foreign body, clean wound, administer appropriate antibiotics, e.g., clindamycin plus vancomycin. Supportive therapy, IV fluids, monitoring organ function. In severe cases, methylprednisone, corticosteroid, to inhibit TNF-alpha synthesis. Kawasaki syndrome, possible association with Staphylococcus aureus superantigens. Acute systemic vasculitis in early childhood, usually self-limiting, but coronary artery aneurysms occur in 20 to 30%, leading to morbidity and mortality. Clinical features: persistent high fever, strawberry tongue, conjunctivitis, maculopapular rash, erythema and edema of hands, feet. Identification of Staphylococcus in samples. Clinical sources: frequently isolated from pussy, tissue, exudates, sputum, urine, blood. Laboratory identification methods. First, cultivation. Grows well on nutrient agar, blood agar, and selective media, e.g., mannitol salt agar. Colonies. Round, smooth, convex. As Aureus often produces golden yellow pigment. Second smear, microscopy. Gram staining, Gram Positive Cocci in clusters, grape-like. Non-motile, non-spore forming. Third, detection of cytochrome oxidase. Staphylococcus species are oxidase negative, helps differentiate from Micrococcus, which is oxidase positive. Fourth, Catalase test. Catalase positive. Production of bubbles when exposed to hydrogen peroxide. Differentiates Staphylococcus, positive, from Streptococcus, negative. Fifth, Coagulase test. Staphylococcus aureus is coagulase positive, clot formation in plasma. Distinguishes pathogenic Staphylococcus aureus from coagulase negative Staphylococci, co-NS. 6. Test systems. Automated identification systems, e.g. API Staph, VTEC, MALDI-TOOF. Molecular methods, PCR for MECA gene, MRSA detection. Clinical concerns and treatment of Staphylococcus aureus. High resistance to common antibiotics. Around 95% of S. aureus strains produce penicillinase, making them resistant to penicillin and ampicillin. Methicillin-resistant Staphylococcus aureus. These strains carry resistance genes against multiple beta-lactam antibiotics, posing major clinical challenges. Multi-drug resistance. Certain strains show resistance to almost all major drug classes. Vancomycin often remains the last line of effective treatment, but reports of vancomycin intermediate and vancomycin-resistant Staphylococcus aureus are emerging. Surgical management. Localized abscesses must be surgically drained or perforated, since antibiotics alone often fail to penetrate pus effectively. Systemic infections. Severe infections, e.g., septicemia, pneumonia, endocarditis, require intensive, prolonged antimicrobial therapy, sometimes involving combination regimens. Clinical implications. Infections caused by resistant strains are associated with higher morbidity, longer hospital stays, and increased mortality. Infection control measures, hand hygiene, isolation, decolonization protocols are critical to prevent spread in healthcare settings. Prevention of staphylococcal infections. Universal precautions. Healthcare providers should strictly follow universal precautions, gloves, masks, sterilization, hand hygiene, to minimize nosocomial, hospital-acquired infections. Hygiene and cleansing, regular hand washing, proper wound care, and disinfection of contaminated surfaces reduce transmission. Screening and isolation. Screening high-risk patients, e.g., carriers of methicillin-resistant Staphylococcus aureus, and isolating infected individuals help control spread. Rational antibiotic use. Avoiding unnecessary antibiotics reduces the emergence of resistant strains. Decolonization strategies. In certain cases, carriers may be treated with topical antimicrobials, e.g., mupirocin, or antiseptic washes, chlorhexidine, to reduce colonization. Staphylococcus epidermidis. Source. Type of infection, mostly hospital-acquired, nosocomial. Sites of infection, frequently infects intravenous catheters, prosthetic heart valves, joint prostheses, and other implanted medical devices due to its ability to form biofilms. Clinical manifestations: sepsis in neonates, prosthetic valve endocarditis, infections related to indwelling devices. Staphylococcus saprophyticus. Source: type of infection, usually community-acquired. Clinical manifestation: a common cause of urinary tract infections, especially in sexually active young women. Differentiating: feature: unlike Staphylococcus epidermidis, it is novobiocin resistant, a key lab test for distinction. Thank you so much for watching. Don't forget to subscribe to my channel, press the bell icon button. Thank you!